Okay, hello everyone and welcome to DOW 2002 CPD webinar series organized by the class of 2002 DOW Medical College. This is the first CPD webinar of 2020. Thank you very much everyone for joining us today. We have two excellent speakers, one from across the Atlantic and one from the UK. So our first presenter is Dr. Faiz Rajobali, who is a medical director of lung cancer screening programs at Phoenixville Hospital in Pennsylvania, America. And Faiz is going to talk to us about bronchoscopies, diagnostic as well as therapeutic utility of bronchoscopies. So Faiz, over to you.
Thank you. Assalamu alaikum, everybody. This is going to be like a very informal talk about bronchoscopies. Bronchoscopy is used a lot by pulmonologists. We do that on an almost everyday basis, and we use it for diagnostic purposes and also therapeutic purposes. So it's just a very brief overview of what we do in terms of bronchoscopies. So bronchoscopy is usually either done as an inpatient or as an outpatient. Both serve the same purpose of trying to get more information from what's going on from our patients, or also to treat whatever we know already what's going on. Bronchoscopies are usually either first brought up by the pulmonologist himself or herself, or we have one of the primary teams or another consultant who requests a bronchoscopy, usually like an oncologist or rheumatologists who have a complex patient and they want more information as to what's going on from a pulmonary standpoint. So bronchoscopies done usually under anesthesia. It can be done with general anesthesia or done with the Twilight or MAC, which is the done with like Versed and fentanyl anesthesia. So we have two main types. One is flexible bronchoscopy and one is rigid bronchoscopy. We don't do as many rigid nowadays. A lot of what we need to do gets accomplished by doing the fiber optic flexible bronchoscopy. So flexible bronchoscopy, usually you do it for a diagnostic purpose. So you can do a bronchoalveolar lavage, you can do a bronchial washing, you can do a brush biopsy, you can do a forceps biopsy or needle aspiration. And therapeutic is done through the same method as well. Just of note, whenever a bronchoscopy is done, it is preferred to be done in a negative pressure room because you don't know what you're dealing with. This can be an infection. So being in a negative pressure room takes away the chance of getting droplet or what's the other one? To avoid getting other people contaminated. Flexible diagnostic bronchoscopy can be used for pneumonia. A lot of times pneumonia gets diagnosed either clinically or you get a sputum sample, but sometimes you have other complicated patients who might have TB and or pneumocystic pneumonia. TB is a very big thing because if somebody is not diagnosed and placed in isolation on time, then you have to go back and try to figure out how many people have been exposed to this particular patient and get them tested for TB, which can be a very high cost implication, and it's a big headache for the hospital. So whenever somebody comes in with even a suspicion of TB, they get placed on isolation, and then we get the privilege of doing a up close and personal investigation right in the patient's airway to diagnose TB. Pneumocystis carinii can be, or PJP now, can be either from HIV patient or also non-HIV patient. Nowadays, we have a lot of these biologics being used for different conditions. You're getting more and more PJP being diagnosed. Or if you have a patient who have a persistent infiltrate in their lungs and nobody can find out, they keep coming back, getting treated for pneumonia, rounds after rounds, and the infiltrate is still there. And the question is, what we're looking at on a CAT scan, is this still an infection, or could it be COP, the cryptogenic organizing pneumonia, formerly called BOOP, or could it be, you know, something else like cancer? Interstitial lung disease also being diagnosed more and more nowadays. A lot of times your CAT scan can give you a pretty good idea as to what kind of pattern of infiltrate you're looking at: NSIP, UIP, DIP, a lot of interstitial pneumonitis. And doing a bronchoscopy with both a lavage or a biopsy can give you the diagnosis as well. A mass in the lung, a very good reason to do a bronch, either a central mass or a peripheral mass or nodule. Difference between mass and nodule is about the size. Something which is less than 2 centimeters is usually called a nodule. If it is greater than 2 centimeters, it's called a mass. Foreign body, also a good reason to do a bronch. Somebody comes in, might have aspirated something either while eating or accidentally choking on a foreign body. You get a bronch and you can either see it and or treat it. Cough, very challenging. You have patients with cough which has usually chronic cough for more than 6 to 8 weeks. Patients coughing, can't figure out why. A bronch can a lot of times give a good idea. Other indications: somebody comes into to the hospital for whatever reason, gets a CAT scan, finds that they have enlarged lymph nodes, they have a neuropathy, and they get sent for a bronch, which can be done either as a fiber optic bronchoscopy or an endobronchial ultrasound, the EBUS, which gives us very good information. Trauma patients: somebody comes, trauma, either motor vehicle or penetrating trauma, they have an airway which is damaged. You can do a bronch, see where the lesion is, and sometimes fix it, either putting glue in the airway or then call your cardiothoracic surgeon, say, hey, there's a lesion on this side, can you just ligate it or you know, do whatever needs to be done. Hemoptysis, very common as well. People coming in for whatever reason, coughing up blood, call the pulmonologist and they'll find out what's going on. So then take the patient for a bronch. Just Friday, I had a 29-year-old who I did a bronch, came in with chest pain and coughing up blood. Looks like he had diffuse alveolar hemorrhage. So we're working him up for a possible vasculitis. Vocal cord dysfunction, people again coming with different presentations, can be cough, hoarseness, and turns out they have a vocal cord dysfunction, either trauma from prior intubation because of surgery or because they're in the hospital. And you find out that their vocal cords have some problems, either not moving paradoxically, or even have a node on the vocal cords. Other reason, tracheomalacia or tracheobronchomalacia, people have very floppy airways. And you do a bronch, you can see that the airways are collapsing whenever they cough or they take a breath. And this is usually a benign condition, but sometimes needs a stent. Smoke inhalation, people who have been involved in smoke injury or fire injury, they might not get direct burn, but they can inhale smoke. And that can lead to damage of the nasal passages, the trachea, the whole airway can be affected from that. And a bronch is a very good way of inspecting the airways. Other diagnostic use of an bronch is an endobronchial ultrasound. Your typical bronch has a light source, also a fiber optic camera, which you get the pictures from. An endobronchial ultrasound also has the camera, the light source, but it also has an ultrasound at the tip, which allows you to look through the airway and look at a node, look at a mass or a nodule, which you otherwise won't be able to see directly when you are looking through the airway. And the reason why people usually get an EBUS done is because they have some adenopathy related to known or unknown cancer. They might have central or peripheral tumors, or sometimes even cysts. There are two types of EBUS. There's the linear EBUS, used mostly for your central lesion, and then a radial EBUS, which is a probe with a rotating ultrasound that you can put through the scope, and it goes distally to the peripheral lesion. And these are all done with real-time ultrasound. Another use of bronchoscopy is called the navigational bronchoscopy. There's two types of navigational bronchoscopy. One is a virtual bronchoscopy. The other one is an electromagnetic bronchoscopy. Electromagnetic one, you need a mapped room because the bed, the walls and everything has to be mapped because you're using an electromagnetic field to guide your scope to go to a particular lesion. The virtual bronchoscopy, you have to do a special kind of a CT scan with a certain number of cuts, usually about 200 to 300. Then you upload these in your computer, they regenerate the picture, and then you get, usually we call it like a GPS for the lung, and it gives you a road map to take you to that particular lesion. Once you get there, then you can do your biopsies. As far as therapeutic ports are concerned, like I said, hemoptysis is a very good indication to do a therapeutic scope. Not only does it allow you to find where the bleeding is coming from, but once you find it, you can either do a cauterize the lesion if you see a lesion in the airway, or if you have bleeding coming from the alveolar side, like the alveolar hemorrhage, you can also localize that. Sometimes you see clots in the airways, and you can remove the clot. Removal of a clot is pretty challenging because as you use a forceps, you try to take it out, it breaks, so it becomes a very tedious process. But if you have something called a cryoprobe, you can just freeze it and then just take the clots out. Just a quick mention, usually people don't bleed out in the lungs. You're not going to lose an extra large amount of blood in your lungs, but it's mostly blood in the lung that occludes the airways, and then you cannot have any gas exchange. That can lead to suffocation and maybe even death. So usually patients don't bleed out in their lungs, but there's enough blood in there that it occludes the airways. Also, when somebody is bleeding, the benefit of doing a bronchoscopy is you can tell if the blood is coming from the right or the left lung, and then you can do a selective intubation. So if the patient is bleeding from the left, you do a right main intubation. So you intubate the right lung, you inflate your cough. This way no blood spills into the good lung. If you have blood coming from the left, we can figure out how to deal with that, but at least you preserve one lung to maintain ventilation and oxygenation. You can use things like airway blockers, kind of like sometimes in GI, you put a sense-taken Blackmore Minnesota tube into the esophagus, you inflate it, you not only cause direct compression to stop the bleeding, but prevent the blood from coming out and going into the lungs. All of these can be done fairly quickly, and once you've secured the airway, then you can find either your cardiothoracic surgeon or whoever you want to call for help to deal with the bleeding. But sometimes even interventional radiology can do embolization of the bronchial arteries and stop the bleeding. Next, with flexible therapeutic bronchoscope, you have things that you can put in the scope in your working channel. You can put baskets, you can put forceps to do biopsies, or if you have an airway which is blocked by a tumor, you can use different means to try to debulk the tumor. I use something which is called the APC, the organ plasma therapy. And it has a gas, the organ gas, which goes into the airway. There's a small spark and it lights it, and then it burns the lesion you're looking at. You can use it for debulking a tumor, or if somebody's bleeding, you can use that and just paint the airway, and then it cauterizes all the small blood vessels, stops the bleeding. You can also use a forceps to debulk tumors, and you just you can burn the tumor and then use the forceps and debulk it and take small bites at a time, and open up the airway. Also, like I mentioned, the cryoprobe, which uses liquid nitrogen in a probe. You can use that not only to stop bleeding, but to take out clots, and also to patients who've had a trach. They sometimes get more lesions in the airway, and those causes obstruction. And we've seen that when you use heat in the form of electrocautery, you take away those lesions. It has a tendency to grow back. But if you use cold, the cryo freeze, then it doesn't grow back as quickly. So you preserve the integrity of your trachea and get your obstruction out of the way. If using a flexible bronchoscopy is not going to help, then you can use a rigid bronchoscope. A rigid bronchoscope is usually done only in the operating room. It is a pretty gruesome kind of procedure. You're literally taking like a rigid hose and then sticking in somebody's airway. It has a high risk of rupturing the airway itself, but it's usually not the first line of treatment that we'll use. But nonetheless, it's like your rescue therapy if nothing else works. Tumors in the airway, once you've diagnosed them using an EBUS or a wash or a brush or forceps biopsy, they obviously can bleed. And bleeding in the airway is tricky because, again, it clots the airways. It can lead to asphyxiation, suffocation, and impaired gas exchange. So you want to minimize the bleeding. And two things that work. One is ice cold saline. So you have your saline and you have your nurse keep it on ice, and you just use small amounts of that, and it freezes, not freeze, but it stops the bleeding. The other thing you can use is diluted epinephrine. You take one small vial of 1 milligram of epi, mix it in 19 cc's of saline, and you use small amounts of that at a time. You put it on the airways. That causes vasoconstriction and stops your bleeding. Electrocautery, like I mentioned, is also good to stop bleeding, but it can cause more regeneration of tissues, and that can lead to more obstruction of the airways. Cryotherapy is good, but not.
Guys, we have 2 more minutes.
Okay, all right. Cryotherapy, like I mentioned, organ plasma, laser is also something you can use to debulk tumors. And as far as therapeutic is concerned, for cancer patient, you can put something called small beads of radiation called brachytherapy, and that can do very localized radiation and help with the cancer patients. Another thing that we do is fiducial marker placement, and that is used for CyberKnife. If you have an airway which is compromised, you can put a stent, you can put it over the wire that opens up your airway, and that allows patency of the airway and allows for gas exchange. And that can be temporary or permanent depending on what you're treating. This is a picture. I don't know how well the picture shows. I was pretty convinced this was somebody who had a tumor in the right lower lobe, but it turns out it was aspirated food that had been sitting there for a while, and it was a mixture of steak and vegetable. This was a squamous cell lung cancer, what you can see on in the airway. This is another tumor in the airway, and after burning it, it looked kind of like that. It just start to open up the airway. This was somebody who got a pneumothorax from aspirating a pea while eating pea soup. I was able to get the pea out in almost this whole of it, and that was the pea that was stuck in his right upper lobe. So that's a quick overview of bronchoscopy, therapeutic, and diagnostic. I mean, in 20 minutes, it's pretty short time to go over all of that, but we'll be happy to take questions afterwards.
Thank you very much, Faiz. Very good. Excellent presentation. If you could kindly stop sharing your screen so Amir could upload his presentation.
Sure.
We'll take questions in the end. So our next speaker is Dr. Amir Zaidi, who is a consultant neurologist working in the NHS now. He was trained in the NHS. Then he went to Canada and did some further training. And now he's back working here in Leeds General Infirmary. And Amir has a special interest in headaches. So he's going to give us hopefully a very good, fascinating talk on headaches, different types of headaches, and how to manage them. So Amir, over to you.
Naseem, can you?
Yeah, we can hear you now, yes.
Okay, and
we can hear you, yeah.
Okay, so thank you very much, Naseem, for the introduction, and assalamu alaikum to everyone. I actually, just a slight correction in introduction. So I went to US, not Canada, for the fellowship, and I did the fellowship in movement disorders. I do have an interest in headaches. I have done a couple of years headache clinics in Preston. Okay, so I'm going to go through the common type of headaches. Obviously, in 20 minutes, we cannot, there are more than 50 types of headaches, so I can only talk about a couple of common type of headaches and then the common secondary headaches. And the talk is more about treatment options. So it's more about headaches for the non-neurologist. So some basic introduction of headaches and different types of headaches. So this is the outline. So I'll go through the introduction, classification of headaches, common primary headaches, some secondary headaches, what are the red flags to look for in history, and important question, when to order the imaging, and what other headaches should not be missed. So headache is actually a global problem. So it's a worldwide problem affecting all ages, races, income levels, geographical areas. Nearly half to 3/4 of adults between 18 and 65 years had headaches last year, which means that like last year, this study was done 2017. So in 2016, almost 3 billion individuals were estimated to have headache disorder. Out of those, 1.89 had tension type headaches, and 1.4 billion, 1 billion people had migraines. It is a leading cause of disability. It's a 6th most common cause of disability on the planet, with more than 1 billion patients having an attack in any year. And migraine is estimated to have caused 45 billion years lived with disability in 2016. And tension type headaches caused 7.2 million years lived with disability in 2016. It is a huge financial burden, costing the US about 19.6 billion and European Union 27 billion euro annually. So this is just a slide about the burden of headaches. So you can see it's more the two most common type of primary headaches, migraine and tension type headaches. The top one is the migraine. is less prevalent than tension type, but the disability burden is much more with migraine as compared to the tension type headache. The most common age group is between 20 and 50 years. Classification of headaches. So International Headache Society published the classification ICHD, International Classification of Headache Disorder, last year. And they classified, they normally update the classification every few years. So they classified the headaches in the broad range as a primary headaches and secondary headaches. So the most common primary headaches are migraine, with or without aura, tension type headaches, trigeminal autonomic cephalgias, and other primary headache disorders. And there is a list of secondary headache disorder, depending upon which part of the head is affected, vessels are affected, or due to infections, due to other disorders going on in the rest of the body, like malignancies, like problem with the homeostasis and XYZ. So I'm going to talk about the common type of headaches. So the most common primary headaches are tension type headaches. So lifetime prevalence is around 90% and 1 year prevalence is of 38%. Commonly, people between 30 and 39 years of age are most likely to be affected by the tension type headaches. So the criteria given by the International Classification of Headaches, tension type headaches, again, the most important thing is the history. So in the history, any headaches, you talk about the duration of headaches, you talk about the frequency of headaches, and then you talk about the nature of pain. So these are the critical points in the history. Tension type of headaches are divided into usually infrequent episodic tension type headaches, frequent episodic tension type headaches, chronic tension type headaches. So it depends upon the history. If the headache is less than 1 day a month, then these headaches are episodic infrequent headaches. If the headaches are happening like between 1 and 14 days a month on average for more than 3 months, but less than 180 days in a year in total, then those are frequent episodic tension type headaches. Chronic tension type headaches are the headaches that usually happens that usually affects more than 15 days a month and more than 3 months consecutively and more than 180 days in a year. So chronic headaches, either tension type or chronic migraines, they have to be more than 180 days in a year. So tension type headaches, important features of tension type headaches are that they are usually bilateral. If the headaches are unilateral, it almost exclude the tension type headaches. So headaches are almost always bilateral. And the character of headaches is usually like a pressing headache. Patients usually say that I've got a pressure in my head. They say my head is going to explode. So that kind of pressure headache is a typical of tension type. Usually mild to moderate intensity that differentiated from the typical migraine that causes disability. And the important point, the next point, not aggravated by routine physical activity like walking, climbing stairs. Again, this point is crucial because that differentiated from migraine, because migraine affects the physical activity. The last features you can see, no nausea or vomiting, again differentiated from migraine, no more than one of photophobia or phonophobia. So the patient may complain of photophobia or phonophobia, but not both of them. So common risk factors for tension type headaches, people with hypertension, more common in females, people with head injuries, being a student, anxiety, stress, and problem with the temporomandibular joints. How do we treat the tension type headaches? It depends if the headaches are infrequent or if the headaches are frequent or chronic headaches. Infrequent headaches are treated by simple painkillers, paracetamol, and NSAIDs. So the NSAIDs most effective are the ibuprofen or naproxen, or you can use a combined NSAID plus the paracetamol. The important point, the take-home message from this slide is that try to guide the patients about the medication overuse headaches when you prescribe them with the simple analgesics like naproxen or ibuprofen. Anyone taking these medications more than 3 days a week, more than a couple of months, they are bound to get medication overuse headaches that would complicate their underground migraine or tension type headaches. Now, the chronic tension type headaches, you use the preventive medication. The preventive medications are usually most commonly, and evidence-based medications are tricyclic antidepressants. Commonly used amitriptyline. The crucial point here is, again, the dose. The doses usually prescribed by the GP are like 10 milligram. That is not going to touch the tension type headache or any chronic headache. So that's one of the most common reason why patients' headaches do not get better. So the important point is the dose. So it has to be the therapeutic dose. Amitriptyline should gradually go up 10, 20, 30. Between 30 and 40 is the good dose. It can go up to 75. Similarly, the venlafaxine, mirtazapine can also be used as a prophylactic medication. In tension type headaches, if the antidepressants, tricyclics are not working on their own, then the combination of tricyclic with the muscle relaxants like tizanidine or with the topiramate, the antiepileptics, they can be very effective as well. So non-pharmacological options for the tension type headaches, there is some evidence that acupuncture does help. Diet help as well. Diet means avoiding the caffeine, avoiding the sweeteners help. Cognitive behavioral therapy, relaxation techniques, and neck massages. Also, there is evidence that those strategies also help with the tension type headaches. So the second most common type of primary headache is migraine. So recurrent headaches usually lasting from 4 hours to 72 hours. So duration is very important. Typically unilateral as opposed to the tension type headaches, typically throbbing type pain, pulsating pain, as opposed to the pressure-like pain. Intensity is usually moderate to severe. And as opposed to tension type headaches, migraine does affect the routine physical activity. It gets aggravated by the physical activity. The other features, nausea, photophobia, phonophobia, are very common in migraine. Migraine, then the most common migraines are without auras. Migraine without aura criteria is lasting from 4 to 72 hours, one-sided pulsating pain, moderate to severe, and as previously aggravated by physical activity. And nausea, vomiting, and both photophobia and phonophobia. Migraine with aura, similar kind of pain, but associated with fully reversible either visual, sensory, or motor or brainstem related any kind of auras. The important thing is those auras should be reversible, should be spreading gradually, and either before the headaches or during the headaches. Diagnostic criteria, at least 2 attacks, as opposed to migraine, in which you have to have 5 attacks. With aura, you can diagnose migraine with aura with 2 attacks of any of these reversible auras. And as described previously, unilateral headache, throbbing headache, and with photophobia, phonophobia. Aura should continue for maximum 60. Aura can continue up to maximum 60 minutes. So these are different kind of auras, the visual fortifications. These are these are what patients perceive during the migraines with aura. Typically, migraine have a prodromal phase, then aura, then migraine attack with headaches, then postdromal phase. The important point here is that migraine, the misconception is migraine means headaches. That's a misconception. So headache is only one out of several symptoms of migraine. So migraine usually starts few days before headaches with irritability, depression, yawning, nausea, food craving, sleep difficulties, difficulty in concentration. All of those starts few days before. Then if the migraine is with aura, then the patient of the symptoms of aura will develop. And then there will be the headache for between 4 to 72 hours, followed by the post-normal phase with fatigue, depressed mood, and all of those kind of symptoms. Chronic migraine, like the tension type headaches, lasting 15 or more days a month for more than 3 months. Out of those 15 days, at least 8 days should be of headaches with typical migraine features. So pathophysiology is, I'm not going to go in detail, but the aura symptoms are due to the cortical spreading depression. And usually the pain is caused by the trigeminal vascular system. So if we can all recall the anatomy, so this is the trigeminal ganglion. Trigeminal nerve, as we all know, controls all the sensations affecting most part of the head, face is controlled by the trigeminal nerve. So from the trigeminal ganglion, the fibers goes down to the brainstem and to the cervical level, because the trigeminal nucleus goes up to the cervical level. And from there, the second order neurons then go to the hypothalamus, it goes to the thalamus, and from there it goes to the blood vessels and different parts of the brain, including the visual cortex, including the motor part of the brain, including the sensory part of the brain. So that's how migraine can affect each and every part of the nervous system. How do we treat migraines? So the most important thing is that most of the migraines have some kind of triggers. So addressing the triggers like sleep deprivation, diet, avoiding caffeine, avoiding chocolates, look for the work circumstances. Are you sitting many hours in front of the computer screens? Similarly, looking for like people who have either not eating properly, or sometimes the weather, either cold weather, hot weather, all can aggravate the migraines. So addressing the trigger is the key to start the treatment. Then treating the migraine, there are two important steps. One is the acute migraine treatment, and the second is the preventive medications. The acute migraine treatment is usually for the headaches, episodic headaches, and you treat them with the triptans and with the NSAIDs. These are the two key medications. The important thing in treatment of migraine is to remember that if the patient is nauseous, he or she is not going to take the medications. So important part of the treatment is the antiemetics. So use of metoclopramide, flucloperazine, they are very, very effective in stopping the nausea in migraine. Then triptans, again, as I said previously, the important thing is the dose. Sumatriptan can be used orally, can be used nasally, can be used as injections. But the key is the dose. If you're giving sumatriptan orally, it has to be like 100 milligram. If you're giving nasally, it has to be 10 milligram. If you're giving subcutaneous injection, it has to be 6 milligram. Most of the time, migraine treatment fails because of the subtherapeutic doses that most of the people most of the doctors in the ED, especially, they offer the subtherapeutic doses, or usually at the GP practice, the dose offer is not the right dose. The other important learning point from here is that combining the naproxen along with sumatriptan is much more effective than giving either sumatriptan or naproxen alone. So that's the other key point. The other, if the migraine continues for more than like 2 days, so migraine attacks more than twice a week, so more than 5 times a month, then those patients should be offered the prophylactic medications. So the prophylactic medications, important prophylactic medication are the beta blockers. These are the first line medication in the preventive strategies. These are the doses. Again, the dose is very important. When you treat the patient with the preventive medication, the important instruction is that each medication trial should be continued for 2 to 3 months minimal at the effective dose before the patient considering them ineffective. Again, the patient come to the neurology clinic because they say they were taking like 40 milligram of propranolol, it was not working, they stopped taking the medication. They were taking the amitriptyline 20 milligram a day, not working, they stopped taking the medication. So the message is the correct dose for correct duration. That's the message. So the beta blockers are very effective. Then antidepressants, especially amitriptyline, is very effective. Anti-epileptics, topiramate is very effective. SSRIs or SNRIs like venlafaxine is very effective in treating the migraine as a prophylactic medication. Calcium channel blockers, if the beta blockers antiepileptics don't work, then calcium channel blockers like verapamil, flunarizine are effective. The other second line treatment could be gabapentin, could be pregabalin, carbamazepine. These are like, or sodium valproate, epilim. These are like a second line medication for the migraine. Angiotensin converting enzyme inhibitors, candesartan has been used. There are some positive trials, and not many trials are there, but there are a few positive trials for the candesartan as well. Then there are some nutritional supplements, riboflavin, coenzyme Q10. They are also part of NICE guidelines for the treatment of migraine, especially the riboflavin. Botox is one of the newer treatment, not newer now, but in the last 10, 15 years, it has been used very effectively for migraines. NICE recommended Botox as a preventive strategy for the chronic migraines. And the patient must
You have 2 minutes.
Okay. The patient must have tried at least 2 medications and have not responded. They should be offered the Botox treatment. There are a number of trials which have shown the positive results from the Botox, especially for the chronic migraine. The neuromodulation is effective. These are one of the new treatments. So the non-invasive migraine treatment, especially for the patient where the medications are contraindicated, especially like in pregnancy, the new neuromodulation techniques can be effective. I'll just go in 1 minute to 2 minutes, like a secondary headaches, important ones. So the red flags, important red flags, if there is any change in migraine pattern, any change in headache pattern, if there is a new onset headaches change with the change in position, like worse in lying down or early morning headaches, or if you find abnormal examination during the abnormality on the examination, if the patient has HIV or other if the patient is immunocompromised, any cognitive impairment. So these are the important red flags or systemic signs, systemic symptoms. Neuroimaging, usually in primary headaches, there is not much role of neuroimaging. So the important thing is to look for the red flags. And if you find the red flags, then in those cases, it is important to consider the neuroimaging. Otherwise, it's not worth it. I'll just skip that slide. Important secondary headaches, subarachnoid hemorrhage. The key is the history. The subarachnoid hemorrhage, the headache is sudden onset thunderclap headache. The importance is the definition of thunderclap headache. So headache should go to the peak. Peak means 10 out of 10, ideally within 60 seconds. That is what thunderclap headache is. If headache is building up over minutes, that is not thunderclap headache. So history is the key in the subarachnoid hemorrhage. The important investigation are the CT and lumbar puncture. CT to be done as soon as possible. And usually CT is 98% sensitive within 12 hours. But as the hours goes by or the days go by, the CT sensitivity goes down for the hemorrhage. If the lumbar puncture to be done, it should be done after 12 hours to look for the xanthochromia. So I will stop here. There are a couple of more secondary types of headaches, but I don't think I would be able to go through to those. Okay, thank you.
Good. Thank you, Amir.
Thank you. हो गया चलो अच्छा मैं इसकी आवाज इसका मैंने गला घोटा हुआ था मैं इसकी आवाज कैसे
Okay, guys, I have unmuted all of you, so there is a lot of background noise we can hear. So we will take a few questions now. So please raise your hand. There is an option on Zoom, like Naseem have just raised his hand. So if you want to ask any question, you can raise hand and then we'll take your questions. So Naseem, go ahead.
Good presentation from both Rajab and Amir. And Rajab, I have a question for you and Amir for you as well.
Yeah,
Go ahead.
First with Rajab. Rajab, it was a good presentation, and I would like to know about your experience regarding tracheoesophageal fistulas, because that is one area where I also work. Aside from bronchoscopy, I do a lot of bronchoscopies for foreign body, and being an ENT surgeon, we are trained for that as well. I would like to ask, what is your experience with the tracheoesophageal fistula and stenting in those patients who have these fistula, especially after prolonged intubation and an NG tube placement?
Mm-hmm.
because they tend to develop fistulas after tracheostomy and an NG at the same time.
Right. So, I mean, the most important thing with those fistulas is obviously prevention. We try to avoid keeping the patient intubated for more than 2 weeks. As soon as we're getting towards the 2 weeks mark, we plan on a tracheostomy placement to avoid the fistula complication. But if they do, then they can get like a covered stent.
Uh-huh.
And those help with the healing process. And by then, the patient would also have had a tracheostomy and a PEG tube. So you're not using the esophagus for nutrition. They're going for PEG tube nutrition, and the covered stent can sometimes help with that.
Uh-huh. So how high can you go for the stenting? Because I recently have a patient with a fistula just below the cricopharyngeus level, and the GI person also said that it's difficult to stent here at this level. Obviously, at the cricopharyngeal level, not a pulmonologist or an ENT would not stent that.
Right. I mean, those stents are very tricky because they migrate. It doesn't matter where you put them.
Exactly.
The patients cough and the stents migrate. So it's just very challenging. There's no like definitive treatment that you can say this stent will stay in place and help with healing. Otherwise, one of the things that can be considered is like a resection and a pull through. So you resect part of the airway and you do a pull through.
And anastomosis. That's what is the option for these patients.
Pull through and anastomosis, because otherwise it just won't heal.
You can't do end-to-end anastomosis just near the cricopharyngeus level, because it's just below the vocal cord and subglottic area. You don't have enough tracheal rings to anastomose on the superior segment.
Yeah. I mean, that's a tough,
it's a difficult,
tough situation.
Yep. Thank you. Amir, again, it was a good presentation. It was nice to see you again after a long time. And Rajab too, yes, definitely. And Amir, what about frontal headache? We usually come in patients with frontal sinusitis. So what do you have, anything about the frontal headaches or any sinus headaches? How do you differentiate them from the neurological type of headaches?
Okay, so if the headaches are due to sinusitis, it's again, the history is very important. So going through asking about the nasal drips, asking about the sputum, asking about the history of fever, asking about the tenderness around the sinuses. And obviously the trial of the nasal sprays can be obviously sometimes helpful as well to differentiate it. Frontal headache is very non-specific. So all headaches like migraine, when we said that migraine is unilateral, so it's not like a strictly unilateral headache, because migraine, people can have migraine bilaterally, people can have migraine starting from one side and then moving to the other side. So frontal headache is very non-specific, and differentiating from sinusitis is clinically, it's a clinical differentiation on the basis of features. If you're differentiating from the migraine, then sinusitis should not be causing the phonophobia, photophobia, or other like a brainstem symptoms. So that should differentiate between the two.
Thank you so much.
Very good. Any more questions?
Yeah, if no one has got a question, I've got a question for both Amir and Rajab. I'll start with Rajab first. Thank you very much, guys. Excellent presentations as expected. Rajab, you did mention vasculitis. I do actually see a lot of patients with pulmonary renal syndromes, including anti-GBM and ANCA-associated vasculitis. How easy it is, because we do actually sometimes worry whether this is congestion or pulmonary edema, especially if someone comes in with crashing renal failure. How easy is it to kind of actually bronchoscopy these patients, basically, who literally kind of actually quite unwell? I mean, not most of the times ICU these patients, because we do actually have a renal HDU, and I find it really struggling to kind of convince my respiratory physicians to kind of actually look after these patients, especially when we do need a bronchoscopy to confirm, the pulmonary or alveolar hemorrhages. That's for you, Rajab, and I'll ask him the question later.
Yeah. So if the patient is very hypoxic, I have done several blocks with patients, placing them on BiPAP.
Mm-hmm.
And then through the BiPAP, and you keep them semi-awake. You even do it like in a semi-sitting position, so you don't sedate them completely.
Mm-hmm.
So
Mm-hmm.
keeping them semi-awake using a BiPAP, and through that put the scope, and you're doing it with the patient sitting, you're standing in front of the patient, facing the patient instead of being at the head of the bed from behind. That's one way of trying to minimize how much sedation you give the patient
True.
and how awake you can keep them. The other way that I do the bronchs for these patients is using an LMA,
Mm-hmm.
a laryngeal mask, and that gives me the luxury of having the patient quite sedated, but they don't have an endotracheal tube, so you're not irritating the vocal cords as much. So using an LMA for sedation, and then allows me to do the bronch, do your BAL or biopsies, and then try to wake them up afterwards. But if somebody is comfortable doing a bronch with the BiPAP, would be the better way to try to keep the patient as awake as possible. And at the end of the day, if the patient is not crashing, but is very hypoxic to the point where they do need to be intubated, then I will just electively intubate them, do the bronch, and then maybe keep them intubated for maybe a day or two until things are better, and then get them extubated.
Yeah, sometimes actually we do get ICU, the intensivists actually do that for some of our patients. But that's really helpful. Thank you very much for the answer.
No
And
problem.
for you, thank you very much for such an excellent presentation. I'm sure you do get a lot of questions from the GPs about headaches and when do you kind of actually have to do a CT scan. Some of these patients, intelligent patients who actually Professor Google would come and ask you about CT head scans. How do you escape from actually sort of not doing this CT head scan, but try to actually reassure them about the headaches? And I sometimes find it difficult with some of my renal patients, although I don't do general practice, I do specialist renal medicine. Just some tips for the GPs and non-specialist neurologists, please.
Yeah, I mean, it's a very, very common question in a neurology clinic, and sometimes the patients are referred mainly to arrange the scan, the MRI. That's one of the reasons.
Mm-hmm.
Sometimes the GP refer the patient. The reassuring points are, number one is the duration of headache. So if someone is coming with the history of headaches for a few years, like going on for 4 or 5 years, so I normally tell the patient that, look, if there is something wrong in the brain, for example, if there is a brain tumor, that's the most that's the biggest concern. So I normally say that the brain tumor most often grows rapidly. So it's not going to be like headache going on for 5 years, 6 years, 7 years, and you're still alive, you're still sitting in front of me. So the duration of symptoms is very important. So tell them how the brain works, how if there is any mass in the brain. If there is a mass in the brain, it grows rapidly. So it should cause the other disabilities. And before I talk to them, obviously, when I examine them, so after examination, I include the part of examination in the conversation. I said, okay, if any part of the brain is not working properly, if there is any mass in there, if there is any tumor in there, then, for example, your reflexes should not be normal. For example, you should have like this problem. You should have this disability. You should have pressure at the back of your eyes. I have checked your eyes. I have checked you from head to toe. So everything seems to be functioning normally, which is against the presence of any mass in the brain. So talking about the duration of the headaches, talking about the examination findings, that usually you can use in the conversation to reassure the patient. Also, like telling them about the incidentals. So for example, you do the scans unnecessarily. There is about a rate of 14 to 15% finding incidental findings on the scan. And then patient become more anxious, more worried about the things. So you need to tell them all about those things and to reassure the patient. Having said that, it's still a good proportion of the patient, they don't get reassured about that. And sometimes we often end up doing the scan.
Yeah, you do actually, and
You
there's
can
so
tell
much.
them-
There's so much medical, legal, and defensive practice actually that we all, I'm guilty of as that as well. That you just succumb to the pressure, and sometimes, despite all what you've said, you know, you just end up actually doing a CT scan, and sometimes useless CT scans. But here you go. Sorry,
there's one more way I sometimes deal with them. Like I just tell them, okay, because as I said a number of times during my presentation, the biggest reason of the treatment failure is the subtherapeutic doses and inappropriate medication. Okay, so what I tell them, okay, I give them the medication, the right dose, the right combination. I said, okay, see how you go in the next 3 months. If the things are not better, then we will sit back and then we'll talk about the scan again. That's another way to avoid it.
Sorry, Rajab, you were saying something.
I was just going to say, if Google did, they tell them that Yahoo is saying a different, not to do the scan.
Exactly. Yes. Very good point. And
one more question from Imranul Haq.
Yeah, sure.
Assalamu alaikum to both of you. Very fantastic presentation from both of you, and both are relevant to my specialty. मैं छोटा मोटा ये नहीं कि डॉक्टर कभी कभार ऑर्थोपेडिक्स भी हो जाती है. सबसे पहला सवाल जो मेरा है ना वो है, we do have scoring system to stratify high risk and low risk in hematobasis, upper GI bleed. Do we have similar system in order to stratify low risk and high risk patients who presents to A&E with hemoptysis?
So the hemoptysis is usually massive or non-massive. That's how you would decide if it is, you know, that's a two-way of deciding, is it massive or non-massive?
Patient poor historian hai, it's highly impossible to get a proper history from them or a clear history, especially if somebody is coming from care home or nursing home.
Yeah, so I mean, you ask them, like, were you coughing? Are you coughing every time you're coughing? Are you bringing up blood? And if you are, is it like a dime size, like, you know, a small amount, a big amount? Obviously, whoever is coughing and seeing blood, to them, that's like the most horrifying thing they've ever seen. And the amount is usually more than what it actually is, because it's also mixed with sputum and phlegm at some time. And that's one of the reasons you would do a bronchoscopy to inspect the airway and see is there a lot of blood there, is there a little bit of blood, and that kind of like helps you decide.
Okay, I wanted to ask one question. You mentioned about the 26 billion euros, the burden of headaches. Does that include headaches due to, for example, brain tumors? I mean, if I'm having a headache and then subsequently diagnosed with brain tumor, then does that 26 billion includes cost of radiotherapy, chemotherapy and all that, or is it just the primary headaches we're talking about?
It's a primary headaches, and it's 26 billion is not about the treatment. It's all about also about the people taking time off from work. So especially the people, especially the migraineurs sometimes they take a full 1 week, 2 week off.
Yeah.
That cost include the major portion of that cost include the time you're off work.
Okay, I see.
And I've got a question for Amir. Amir, what's the role of MRI? MRI का क्या role है? अगर SCH के लिए हम patient आता है हमारे पास, तो MRI करने की ज़रूरत है, because at the end of the day we have to do MRI in order to rule out aneurysm, cerebral aneurysm. So
because subarachnoid hemorrhage, the time is crucial. So
sure.
CT enhanced non-contrast CT is extremely sensitive to pick up the bleed.
Up to 98%.
Sorry?
Up to 98%.
Yes, so up to 98% sensitive. So when you have like a modality which is 98% sensitive and very quick and not costly, so that's why you go for that investigation first, CT, because it can be done quickly. CT, and if the CT does not pick up the bleed, then you do the lumbar puncture. And lumbar puncture, if the lumbar puncture is negative, then it is excluded. The subarachnoid is excluded. It's more than 99% sensitive.
Lumbar puncture कौन करेगा? Neurology as a registrar all lazy है. कोई नहीं करता.
Acute physicians, Naseem and colleagues will do that.
आप orthopedic में रहे हैं, आप सिर्फ joint में deal करते हैं.
Lumbar puncture, I mean, it's a very straightforward, quick procedure. 10-15 minutes का procedure है, उसमें कुछ नहीं है. तो वो क्योंकि xanthochromia is very, very sensitive. If the xanthochromia is negative, the important point is it needs to be done after 12 hours. So there have been incidents when the patient arrived and they did the quick lumbar puncture. Lumbar puncture was negative. Patient was sent home and then came back to A&E because of massive bleed. So lumbar puncture should not be done before 12 hours of the onset of headache.
ये अपने consultant colleague को भी बता दो.
Thank you. Amir, just one question actually about, I'm sure you've had, there was a lot of hue and cry about opiates in the UK. GPs have been actually targeted about this because they've been prescribing that right, left and center. Now, what's your take on people who have actually been on long-term use of, codeines and tramadols? I'm sure you see a lot of sort of headaches in those people because, and I've seen that actually in my practice and in my colleagues practice that, small headache, just give them sort of tramadol and codeine, but I don't think actually that is the right thing to do for most of these headaches.
All the neurologists, one thing common, they all hate opiates, especially for the migraine. So if the patient, there are two types of patients. The patients taking the opiates only because of headaches, patient taking opiates for other comorbidities. So the second class of patient, it's hard to deal with because you can't ask them to stop taking opiate. They're taking it for the different reason. But for the headaches, either tension type headaches or migraines or any kind of headaches, opiate is possibly should be at the bottom of the list. So no one should be prescribing opiates for the headache.
Listen to that, Imran al-Haq. Listen to that. All A&E patients are sent with opiates.
यार मैं तो morphine ही लगाता
हूँ. There is a significant risk of medication overuse as well. Plus, opiates will make the nausea, vomiting worse. So migraine patients are the biggest, one of the biggest suffering other than pain is the nausea, vomiting. So that kind of those symptoms are worse with opiates.
यार but patient loves morphine और वो next day तुम्हें gift और card भी देंगे, वो चाहिए होता है हमें.
I think we should conclude our meeting.
Just Naseem, just a question for Rajab. Rajab, you said about bronchoscopy because nowadays I've actually seen a lot of physicians doing that, respiratory physicians. Now, how soon do you sort of incorporate this in the trainees' curriculum? So do you do that actually when they are first year trainees, second year trainee? Because like in renal medicine, our trainees do biopsies and line insertion, VAS cath insertion for dialysis, year 1 and year 2 onwards. How about bronchoscopies and EBUS for your trainees? Day one.
Starts on day one. Yeah.
Okay.
When you do a fellowship for pulmonary and critical care, you're expected to do about 100 bronchoscopies during your 3-year training. But where I was, we did 100 bronchoscopy by year 1. So by the time I was done with my fellowship, I had logged 320 some bronchs. So we do a lot of bronchs, and even for my years of practice, I've kept those numbers as high as I can. So I do about 3 or 4 bronchs a week.
Okay. Thank you very much. Thank you very much. Okay, guys.
Thank you very much, guys. Thank you for 2 excellent presentations. We will upload them on YouTube very soon. There's Amir, excellent presentations. Thank you everyone for joining.
Thank you.
So,
thank you. I'll be sending the certificates soon. Guys who have actually never attended this before, please do send me your emails. And we've got some excellent lines up from February onwards. But thank you, Amir, and thank you, Rajab, once again.
Thank you.
Inshallah next year. Thank you very much.
Thank you, Naseem.
Okay. Allah Hafiz.
Allah Hafiz.